Good evening, everybody. Thank you all for joining in. So once again, we're back with the yeah, Musculoskeletal Ultrasound Society, clinical meetings, wherein we discuss, the day-to-day cases that we see, and we try and discuss uh, the difficulties that we might encounter in day-to-day practice, of course, because in theory and practicals are the same, but in practice, theory and practice is really not the same. Things work out really different that way. And I think this is a good forum where we can, speak about our, clinical experiences. And of course, apart from that, we try and discuss some new topics, some new concepts, which for some reason we might not be really easy to incorporate them into our routine conferences because there's something really new. So just like that, today we have two, really different topics that will be. We have two fantastic speakers that they will be talking on. Dr. Neeti is going to be talking on ultrasound imaging and apophyseal injuries. So
चांगला
that
आहे
is
मी पुढे
something
काय
really
म्हणते
new.
मला
And Dr. Bipin Shah is going to be talking on ultrasound imaging in proximal interphalangeal joint injuries. So both of these, topics, they're more common than what we actually feel they are. But then I think it's a good idea to know about them because you never know when you're going to encounter them. So without wasting too much of time, Dr. Neeti, I think the stage is yours, and please introduce yourself and go ahead with the talk.
Yes, thank you, sir. Good evening to everyone, my respected seniors and colleagues. I hope I'm audible. So I'll just share my screen. To introduce myself, I am presently a consultant radiologist working in Sant Parmanand Hospital, Delhi. And yeah, I report everything general radiology, but after UCAM, I've been getting a decent share of musculoskeletal ultrasound cases, and I'll just like to share one of the interesting cases that I came across. So I'm not being able to share my screen.
Yeah, Hussaina, can you help Dr. Neeti? She wants to share her screen.
Yes, 1 second, sir. 1 second.
Yes. And in the meanwhile, rest of the delegates who are, not the speakers, I would request you to just turn on the mute button because there's a lot of, background noise as well.
Yeah. Is my screen visible?
Yes, yes, yes. Hussaina, can you just make sure everybody's mic is muted? Thank you.
Yes, sir.
Yeah. All right, okay.
Okay, so moving on directly to the case, it was a 14-year-old girl, a badminton player who came with complaints of pain in the right groin region. So the prescription paper just said right hip pain and an ultrasound of the right hip was advised. But when I asked her myself clinically, she pointed to the groin region and particularly to the region of the anterior superior iliac spine, the lateral aspect. She also had a radiograph of the pelvis and both hips. Yeah, so this was the radiograph that she provided. And at that time, before I did the ultrasound, I really, honestly, I could not make out much of any abnormality. Roughly, grossly, I thought the radiograph appeared normal. This was the finding that I saw retrospectively after the ultrasound, that there was this ill-defined lucency in the region of the right anterior superior iliac spine. So proceeding to the ultrasound images, what this is the affected side, the side that she had pain, and this was the contralateral side for comparison. So these are long axis views over the anterior superior iliac spine. What we see here, so remember that it was a 14-year-old girl. So her skeleton is still immature. And what we see here, the curvilinear echogenic structure is the apophysis of the anterior superior iliac spine. And the underlying structure is the subchondral bone. So what we see here is widening of the space between the apophysis and the underlying subchondral bone. So this is termed as apophyseal widening. If you compare with the contralateral side, we see that the curvilinear apophysis is nicely placed over the underlying subchondral bone, and the distance, there's no widening between the two. So what I found here, and this area corresponded to the site of maximum tenderness. So I hope my pointer is visible. Yeah. So this was actually the site of maximum tenderness. So the findings that I mentioned in my report were that there is apophyseal inferior apophyseal displacement with widening of the apophysis and hypoechoic edema and hemorrhage between the within the apophysis with intact tendon attachments. That is, this is the sartorius tendon, which is attaching upon the apophysis. As you can see, it is intact. On the other side, we see the attachment well. There is some hypoechogenicity here because of anisotropy, but otherwise the tendon was intact. On coming to the short axis images, if we again compare the two sides, this is the right side and this is the left side, the symptomatic and asymptomatic side. So here again, we can appreciate the curvilinear apophysis and the underlying irregular subchondral bone and this significant widening between the two. Whereas on the contralateral side, we see normal distance between the apophysis and the underlying subchondral bone. When on color Doppler, there was also neovascularization in the injured apophyseal region. So these are just cine clips. So we can see the symptomatic side showing significant subchondral irregularity and significant uncovering of the subchondral bone. Whereas on the contralateral normal side, we see this curvilinear echogenic structure, that is the apophysis. And again, the underlying subchondral bone, which is not as irregular as the symptomatic side. After a few days, probably the patient didn't have much relief of pain, for which subsequently they performed an MRI just to rule out something that was missed on ultrasound. On MRI also, both the hip joints were perfectly normal as it was seen on ultrasound. And as you can see, this is at the level of the anterior superior iliac spines. There is some haziness in the region here, maybe some displacement of the apophysis here, but there is no marrow edema. And if you see the MRI in the first look, it might almost appear normal if you don't know the exact site of the patient's symptoms. So just the point I'm trying to emphasize is that MRI findings can be quite subtle, and ultrasound findings, as you can see, were quite obvious. So X-ray and MRI findings were very subtle, and the ultrasound findings were very obvious. These are two articles that I found that were really interesting for the same case that I spoke about. Uh, First of all, I'd like to tell you what an apophysis is. So, in a developing skeleton, in a long bone, we have multiple parts. That is the diaphysis, as we all know. Then there is distal and proximal metaphyseal region. Then we have the epiphysis, and between the epiphysis and metaphysis, we have the physeal plate or the growth plate, which is known as the physis. Then we have these structures, the apophysis, which do not actually contribute to the longitudinal growth of the bone, but they are important. It is important for us to know them so that we don't mistake them for abnormal structures or fractures. So there is also a growth plate between the apophysis and the rest of the diaphysis or the long bone. So it is important to know these so that we don't mistake them for abnormality. Coming to the ultrasound findings of normal apophysis and apophyseal injury, as we saw in the case that I showed, the normal apophysis appears as a curvilinear, echogenic, smooth curvilinear echogenic structure with an underlying subchondral plate and minimal distance between the two. So we do not see any hypoechogenic soft tissue here. We see a smooth appearance of the apophysis. Important to remember that the underlying subchondral plate normally also shows some irregularity, so it should not be mistaken for abnormality. But as we saw in the case, the abnormal apophysis appears much more irregular because of traction injury. And this is the ultrasound findings in abnormal apophysis or apophyseal avulsion injury. So here we could see that the apophysis is normally overlying the underlying subchondral bone. And here we can nicely see how the apophysis is displaced away and the underlying subchondral bone, which is normally also irregular, is exposed. And there is an increased distance between the two. So this classifies for apophyseal avulsion injury. These are short axis images. The ones on the left are normal apophysis and the ones on the right are abnormal or injured apophysis. So if you see here, the distance between the apophysis and the underlying subchondral bone is much lesser than that in the injured apophysis. And again, what we see here is the displacement of the apophysis in the on the injured side with uncovering of the subchondral bone. So, especially in the adolescent age group, that is between 12 and 16 years of age, the ossification centers of most apophyses are immature. And because the cartilage is constantly under hormonal influence, it loses elasticity and there is a decrease in the stability of the strength of the osteotendinous junction. So if there are any abnormal forces that are exercised upon them, in adults, the injury occurs more at the myotendinous junctions of the muscles. But because there is this cartilage between the apophysis and the long bone, this cartilage is more prone to damage, and hence apophyseal injuries are more common in the adolescent age group. And we've already gone through the important ultrasound signs of apophyseal injury. One another additional sign that we can see is thickening and ecotectional abnormalities of the tendon insertion. So the tendons that are inserting on the apophysis, and it's in our case was a sartorius tendon, sometimes you might see changes of tendinopathy within it, but it will be intact. There will be no tear. So apophyseal injuries can be chronic or acute. Chronic injuries occur due to overuse and which lead to repeated microtrauma. In chronic cases, the degree of avulsion of the apophyseal structures is minimal. So it does not significantly compromise the biomechanics, and the patient is still able to use that limb, but there will be pain on using that limb. And eventually, when there is healing of this apophysis, the ossification occurs. There are fragments of cartilage within the site of apophyseal injury, which eventually get ossified, and it forms areas of heterotopic ossification. This heterotopic ossification, in fact, sometimes is so frank that on radiographs it can even mimic neoplasms. And hence, history is extremely important. And knowing the exact clinical complaints, the site of pain, and the onset and duration of pain is very, very important to know before you make any diagnosis. Uh, Chronic overuse injuries are more common in the knee and ankle. In the knee, we are very well versed with Osgood Schlatter, which occurs at the tibial tuberosity, and Sinding-Larsen-Johansson disease, which occurs at the inferior patellar pole. In acute injuries, on the other hand, occur due to a single instance of indirect trauma. So there is acute avulsion of the apophysis, and in these cases, the fragment is usually dislocated further away from the growing apophysis. In fact, even eventually, it can even be transformed into a permanent ossicle. So this occurs because of excessive traction force, which is excessive and relative to the resistance posed by an apophysis, which is not fully mature. And the most common site for these acute apophyseal injuries is the pelvis. Um, Pelvis and elbow, but most commonly we see them in the pelvis. In fact, the most common cases of apophyseal injury that I have seen have been in the pelvis in young athletes. Now, Why is ultrasound so important? Because from my personal experience, um, it definitely has a better like role in apophyseal injuries as compared to radiographs and MRI, especially in cases which do not have frank apophyseal displacement. So POCUS, which is focused ultrasound at the site of abnormality, it has the potential to be a screening method for diagnosing apophyseal injuries in adolescents. So when an adolescent athlete or adolescent patient comes to you, pointing at a site of pain where you know, oh yes, I know an apophysis is usually present here. You can immediately, your mind can go to apophyseal injury. And if you place your probe there and you get these classical findings that I've shown, you can directly make a diagnosis of apophyseal injury, and you will prevent any further investigations that are required. So, in comparison with MRI, as I said, another big advantage is that you can examine the patient clinically yourself. The patient can point with a single finger at the site of maximum pain. You place your probe there and you get your ultrasound findings. And as I showed you on radiograph and MRI, the findings were very subtle, and ultrasound is able to identify even minimal cartilage and bone abnormalities. In minor apophyseal injuries, in fact, it acts as a complement to radiographic examinations, and it can be adequate for diagnosis and characterization, as I've experienced in few cases till now. Unlike radiographs, it can also demonstrate the other soft tissue details of the pelvis. It can rule out other muscle injuries, nerve injuries, tendon injuries, and hence it is more comprehensive as compared to radiographs. Lack of awareness of this presence of these apophysis and apophyseal injuries can lead to misdiagnosis, such as muscle strain or ligament injury. So again, when an adolescent patient presents to you with pelvic pain or pain in the knee or elbow or anywhere where you know an apophysis is going to be present, especially when they are engaged in chronic overuse activities, especially sports related, then POCUS can be really effective in differentiating apophyseal injuries from other pathologies. The treatment of these apophyseal injuries is mainly conservative, especially when the apophyseal displacement is minimal or mild. And surgery is indicated only if there is displacement more than 2 centimeters or 20 mm. It was a very short demonstration. Thank you. This is my favorite physicist. I don't know much about him, but I follow a lot of his quotes. So what he says is that teaching for teaching anybody and for learning a topic more in detail, you pick it up and study, explain it to someone, identify any gaps in your understanding, and then return back to the topic to fill in those gaps and understand it better. Thank you.
That was wonderful, Niti. I mean, I really appreciate the plethora of cases that you've shown. And I
Thank
admire that more because I often don't get this kind of injuries in my clinical practice. So I would say I appreciate that even more. So tell me
thank
one
you.
thing. I'm sorry I missed the initial part. Where do you primarily work?
Sir, I work at Sant Parmanand Hospital in Delhi.
So you get these kind of injuries quite often, is it?
Actually, so we have a sports academy nearby. Um,
Ah,
so they bring in quite a few young athletes from there.
yeah, you're
And we
lucky to
have a
get
lot
that.
of akhadas around our hospital. So we have many wrestlers. So they come in
Wonderful.
mostly with ischial tuberosity, apophysitis,
Oh,
hamstring, uh,
right,
at the
right,
attachment of the hamstring.
right. Wonderful. Wonderful
Thank you.
collection.
Thank you, sir. Thank you.
Yeah.
Yes, I think that was a fantastic topic, and of course, the case was also really good. So I agree with you. Uh, the challenge with apophyseal injuries is, with ultrasound, you can actually do that clinical examination yourself, and that will make you more confident. In making that diagnosis, especially in that immature skeleton, which, there are so many pitfalls. You need all that information from the radiographs, from the clinical, presentation, what the patient is telling you. that's how we can make that diagnosis. But yes, that was a really nice case. Good.
Thank you, sir.
It's
So,
true. I just wanted to ask you one thing. Is there any role of dynamic study in diagnosis of this kind
Any
of
role of what?
dynamic study?
Okay.
Ma'am, I have not tried, and the articles that I read also, it was not mentioned anywhere. But definitely, I think I leave it to the seniors to enlighten us on that. If we can do any perform any dynamic maneuver.
See, logically, if you're talking about dislocation, any dislocation is highlighted with dynamic maneuvers.
Yeah,
So
then
logically, it should be useful. But then again, I said I have no experience in this kind of injuries. So I guess you can start trying that from your patients next time.
No, I
Ma'am,
think
only one
what
thing. Sorry.
sorry, Amnik. I'm sorry,
No,
sorry,
no,
sorry.
no, ma'am, you
No,
can
I think
continue.
what Upasna was asking was that in apophyseal injury, which is commonest, tibial tuberosity, dynamic scanning actually gives the grading of 1 to 5. So I think, isn't that Upasana? You're drawing the parallel from tibial tuberosity, right?
I got
Yeah.
some articles. That's why I'm just
But
asking.
with the see, because knee is a dynamic structure, but dynamic only I have just seen in the tibial tuberosity apophysitis. Others I don't think, but there were a couple of points that I wanted to make, Neeti. That was a fantastic
ma'am.
diagram you drew. So the difference between apophysis and epiphysis is that epiphysis, even though both of them are the ossification centers, but epiphysis is always covered with the articular cartilage. Apophysis is not. And
Right.
the other, so we need to understand that the Salter-Harris injuries are epiphyseal injuries, not apophyseal. That's one thing. And when you said the 12 to 16 and you come from sports background, nowadays what's happening is that in female athletes, the apophyseal injuries, particularly of the pelvis region, are coming in higher age groups because, see, as you said, they are hormonal dependent. So there is a suppression of estrogens in females, as a result of which the apophyseal injuries are coming in girls even as old as 18, 19. So in female athletes, because the patient is going to be 18 or 19, it should not be said that it cannot be an apophyseal injury because their estrogens are completely suppressed and they land up with. So this is a big caveat that needs to be understood when it comes to female athletes. And the other thing is that epiphysis always forms a joint. Apophysis doesn't. So the apophyseal injuries that's why they can be managed conservatively. So those are just a few points. But I think, Ankit, we decided that Sir is going to make his presentation and then we'll go for an open question and answer.
Other important site is at the origin of the hamstring tendons. You see the injuries of the ischial tuberosities.
Right, sir.
And as Neeti said, we see commonly at the proximal attachment of the patellar tendon, that is sliding Johansson syndrome, where there is a apophysitis of the lower pole of the patella, That is like in contrast to Osgood Slater disease, which is at a distal end. But and I think other site is also the attachment of the tendo Achilles, where we see the apophyseal injuries. I don't know what is it called, Sievers disease?
Sievers
disease.
Sievers
Yes.
disease. So these are the
Sievers is osteochondritis. Osteochondritis.
No, it is when there is a
apophysitis.
It is apophysitis.
It becomes when there is a spasm and there is a separation, it becomes apophysitis. It's also called as Sievers.
Yeah.
And without a radiograph, that is one challenging diagnosis to make only on ultrasound. You have to have that really high index of suspicion.
In my opinion, Ankit, all lateral X-rays of children less than 13s look like Sievers to me. All of them.
True.
The
I completely
irregularity,
agree.
The density, you're always
Hmm.
wondering, बुला कर लेकर
Especially
आओ,
the
दबा कर
density.
देखो.
Especially the density.
Yeah.
Right. Okay.
Yes. So, uh, so with this, I think if there are any more questions, we can discuss after this second talk. And yeah, so I think Dr. Bipin Shah can start with his presentation. And yes.
Yeah. Can you see my screen?
Yes, sir.
Yes. Okay. So, good evening to everyone. And, for quite some time, I was thinking of, presenting this talk. What we have seen in for, last 1.5 year of practice, there's a lot of references coming to us from the hand surgeons for the evaluation of the PIP joint injuries. And with the advent of the high frequency, particularly hockey stick probes, the resolution being so good that we can see excellent soft tissue anatomy. And most of the time, because this injuries involve the periarticular soft tissue structures where the bones are normal, can be very well evaluated. One reason being the high frequency probe gives an excellent soft tissue contrast. Secondly, this patient usually have a contracture deformities, and to subject this patient to an MRI is really a challenge, particularly if you don't have dedicated finger coils and if you don't have a 3 Tesla MRI. So these are the areas where the ultrasound scores over the MRI, and the biggest advantage is the dynamic examination. Now, keep in mind that we are looking at a very, very thin, small structures, which can be very well evaluated by the ultrasound. But the challenge is the anatomy and knowing the various structures that are involved by the injuries. So I hope that I can explain. There's going to be a lot of anatomy. I hope I clear I present this anatomy very well. So most of the delegates who are attending today will understand the anatomy of the fingers. Normally, what happens in our basic course, we don't uh, teach bony and soft tissue anatomy of the fingers because it is not a part of the ESSR guidelines. And 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 whatever conferences I have attended, most of the time the topics covered are the routine covered. So we thought, let's talk about something advanced. And this is the one joint which really I was so much interested, and we thought we must present the various pathologies that affect the PIP joints. Of course, because of the paucity of the time, I will be able to cover only the part of the certain pathologies affecting the PIP joints. So with that introduction, let me tell you the PIP joint injuries are very common both among the athletes because of the sporting injuries and among the civilians because of the fall on the outstretched hand. Now, these injuries, if they are not diagnosed in time and if they are delayed, which commonly happens, and if these are suboptimally treated over a long period of time, these injuries lead to the flexure contraction. This the contractions and this stiffness of the finger. This stiffness can result into the extension stiffness or a flexor stiffness. So I am going to present two cases of the flexor contracture of the PIP joint. So let's talk about the pathologies. So my first case is of the 37-year-old male. He is an active athlete who had a injury while catching a cricket ball, and he had an hyper extension injury which resulted into the transient subluxation, and then again it reduced. So this was treated with the routine body tapping, but because of the inadequate treatment, the injury resulted in a deformity of the interphalangeal joint in the flexion position. Another case is the 32 years old female patient. Uh, one second. Yeah, 32 years female patient who had a twisting injury to the ring finger following the fall while walking. And this was approximately 6 weeks ago. And if you look at this, both the photographs, they look similar. Clinically, this picture looks same, and this is what is classically described as a boutonniere deformity. Though the clinical picture looks the same, the underlying pathology affecting the soft tissue structures are different, and I will discuss about this injury as we go along, how the different soft tissue structures were involved in this two injuries. So what is a boutonniere deformity? So boutonniere deformity is classically described as a flexion at the interphalangeal joint and the hyperextension at the DIP joint. But still, what is boutonniere? Well, boutonniere is a term which was described in the French literature, and it is called the spray of flowers, which is worn in the buttonhole. So classically, if you look at the coat, the flowers are worn on the lapel of the coat. A similar appearance also you can see when you try to thread the needle eye of a needle, and when you look at the end on, it appears similar like a boutonniere deformity. So this deformity is called boutonniere because if you look at the intraoperative picture of the patient who had a fixed flexion deformity at the proximal interphalangeal joint, you are going to see the intact lateral band of the extensor tendon, but the central portion, which looks like a defect, through which you see the protrusion of the abnormal soft tissue, which can be because of the frayed the central tendon, or it could be because of the synovitis, or it could be because of the bony projection. So and this is what is called the boutonniere deformity. So let's go back to the basics. As I always tell, the knowledge of the gross bony and the soft tissue anatomy is of paramount importance to understand the underlying pathology. However, before I go to the anatomy, let me remind to all those delegates who have not done the UCAM course or those who are interested in doing it, kindly join our UCAM program. This is going to happen both online and offline. And this is, as Neeti was telling us, this is the diploma program in musculoskeletal ultrasound expert, which is we organize along with the Musculoskeletal Ultrasound Society in collaboration with the University of San Murcia, Spain. So this time we have an online course during the July, that is the 4 Sundays. We are going to have a lectures and of course the on-site program and the August and December. This will be followed by the submission of the thesis, and this is a proper 1-year training program. So I would request all those who want to become a subspecialized in musculoskeletal imaging, this is an excellent opportunity to learn the musculoskeletal ultrasound. So now let's come to the bony and the soft tissue anatomy of the fingers, particularly at the metacarpophalangeal joint and the interphalangeal joint. So if you look at the lateral radiograph, you have the metacarpophalangeal joint. Of course, before I go into the details, I would like to tell everyone, whenever you have a patient with the finger injuries, you must do a AP view and supplement by the true lateral view. Don't do the oblique views, because most of the time oblique views are going to overlook the minor fragment injuries or the dislocation and subluxation. So this is a very, very important carry home message from my talk, those who are involved in the conventional radiography. So let's come back to the anatomy. So the extensor apparatus, or many times people call this as an extensor hood or extensor aponeurosis or a dorsal apparatus, is consists of a extensor digitorum communis tendon, which divides into the central slip and the lateral slips at the level of the proximal phalanx. So that's the division of the central slip and the lateral bands. Now, the lateral bands, if you look at its position, they are situated around the dorsal aspect of the axis of the metacarpophalangeal, or the proximal interphalangeal joint and the distal interphalangeal joint. Now, these lateral slips are supplemented by the tendons of the dorsal as well as the palmar interossei, and they attach to the lateral slips along the proximal aspect of the distal aspect of the proximal phalanx. And in addition, you also have the contribution from the lumbricals. Now, keep in mind, the lumbricals arise from the tendon of the flexor digitorum profundus, and they are situated on the radial side. So the radial side, the lumbricals come and attach to the tendon of the introschiz. Now, this tendon, common tendon of the introschiz or introschi, attach to the lateral slip, and they form what is called the lateral band of the extensor apparatus, which gets attached to the distal base of the distal phalanx. And let me tell you again that this band is situated on the dorsal aspect of the main axis of the interphalangeal joint. Besides this, what we have is now these tendons, if are not supported by the soft tissue stabilizer, tend to subluxate and dislocate. So fortunately, we have a soft tissue stabilizers, which is called the extensor hood. Now, the extensor hood is nothing but this is a combination of the soft tissue, which is made up of the muscles, tendons, ligaments, and the band. So this is what the extensor hood is made up of. And the extensor hood is really, anatomy of the extensor hood is really complicated. It takes a very, very long time to understand. But I will teach only the anatomy which is required by the ultrasonologist to know, so that can be applied in everyday's day-to-day practice for the diagnosis of the proximal and the distal phalangeal joint injuries. So if you look at the extensor hood, as I said, it is a combination of the soft tissue structure, which is triangular in shape. The base of the triangle is situated at the level of the head of the metacarpal, while its apex is situated distally at the level of the distal interphalangeal joint. So it's a triangular structure, and the main function of this extensor hood is to provide the mobility. It is like a loose connective tissue, so it moves backward and forwards when the finger movements are done. And in addition, it provides the stability to the joints of the fingers, and it provides the balance movements. So it coordinates the movements at the metacarpophalangeal joint as well as the interphalangeal joints. So that's the function of the extensor hood. The detailed anatomy of this extensor hood I will talk to you a little later, but that's the extensor hood made up of the multiple tendons and the ligaments as well as the ligaments and the bands. So this extensor hood is stabilized by the soft tissue structure. We have the sagittal bands, we have a transverse reticular ligament, and the triangular ligament. So that's the anatomy. Now let's remove the extensor hood from this image, and I will tell you what is the position of the sagittal bands and the different ligaments and the laminas. So if you look proximally at the level of the metacarpophalangeal joint, we have a sagittal bands. Now these sagittal bands arise from the volar aspect of the metacarpophalangeal joint, where the volar plate is situated. So this sagittal band take origin from the volar plate as well as from the transverse carpal ligament. They traverse on the either side of the metacarpophalangeal joint, and they pass on the dorsal aspect of the extensor tendon. So that's the stability that the sagittal bands provide to the extensor tendon. In case when there is a sagittal band is injured, you are likely to get the displacement of this sagittal band of the extensor tendon either on the radial side or on the ulnar side. And this is a common injury which is seen among the boxers and also among the people, right, those who have a rheumatoid arthritis. This sagittal bands get destroyed or the injured, and leads to this subluxation and dislocation of the extensor digitorum tendons. So that's the anatomy of the sagittal bands. Now let's move on to the soft tissue structure. and this is the transverse retinacular ligament. Now, the transverse retinacular ligament arises from the lateral bands and attaches itself on the tendon sheath of the flexor tendons, which are on the volar aspect. Now, you have, in addition to the transverse ligament, retinacular ligament, you also have the transverse lamina, which arises from the lateral bands, and it attaches to the extensor tendon of the uh, uh, fingers. So that's the, you have a lamina which arises from the lateral band, and you have a transverse ligament which arises from the volar plate and attaches to the lateral bands. So, and in addition to the transverse band, you also have the oblique bands, which go more distally and attach to the middle phalanx of the finger. Now, this oblique bands, sometimes they are sometimes they may be absent, but most of the time they provide the stability to the lateral band. And if these bands are injured or they are contracted, there is going to be a downward displacement of this lateral band, or what is called the lateral complex, which is formed by the lateral slips of the extensor tendon and the tendon from the interosseous as well as the lumbricals. So that's, and then we have another structure which is called the triangular ligament. This triangular ligament is situated at the level of the head of the middle phalanx. This connects two lateral bands, and this it's a triangular shape. The base is proximal and the apex is situated distally. Now, the primary function of this ligament is to keep the lateral bands, or the common lateral bands, in its position, and it does not allow the volar displacement of the lateral bands. And why it is important, I will talk to you little later in following pathological slides. So that's the transverse triangular ligament, which is seen at the level of the middle phalanx. So if you look at the gross anatomical picture at the level of the metacarpophalangeal joint, you have the tendon of the extensor digitorum communis. This extensor digitorum communis on the index side is supplemented by the extensor digitorum propriosus, and on the small finger side or little finger, it is supplemented by the tendon of the extensor digiti minimum. So, but these tendons have got distal to the metacarpophalangeal joint, has a similar anatomy. So that's the extensor tendon. You can see that this is the sagittal band extending from the volar aspect of the metacarpophalangeal joint from the volar plate, and it acts like a sling. It acts as a sling and keeps the extensor tendon in the dorsal aspect of the head of the metacarpal. Now, if you obtain a transverse image at the level of the head of the metacarpal joint, at the metacarpal head, what you are going to see is the central tendon, which is the extensor digitorum tendons, and on either side you have the echogenic structure, which goes around the tendon and attaches to the volar plate, and these are the sagittal bands. So that's the extensor tendon, and on both the sides you are going to see sagittal bands. Because of the anisotropy, these bands appear as a hypoechoic structure. If you obtain a transverse image at the level of the head of the proximal phalanx, at this level the extensor digitorum tendon is divided into three slips. So you have a central slip which is in the center, and on either side you have an echogenic structure. These are called the lateral slips of the extensor digitorum tendons. Now let's come back to our boutonniere deformity, which we described in the patient who in the first my first slides. So pathological hallmark of the boutonniere deformity is the injury to the central slip. So the central slip ruptures, and because the central slip is ruptured, which is the main extensor of the proximal interphalangeal joint, the joint goes into the joint is put into the excessive tension on the flexor tendons. And if this joint is not treated on time, it leads into the contracture of the PAP joint in flexion. So that's the primary pathologic disruption that occurs in a patient with the neglected or a delayed treatment of the injury to the proximal interphalangeal joint. So this is the boutonniere deformity. Let's recapitulate what we discussed earlier. So there is classical boutonniere deformity tells us there is a hyperextension at the metacarpophalangeal joint. There's the flexion at the interphalangeal joint, and there is a hyperextension at the distal interphalangeal joint. Why it happens? It happens because the central slip of the extensor tendon is torn from its attachment at the base of the middle phalanx. It is retracted proximally, and this leads to a sequence of events. And ultimately, if it is not treated or it is suboptimally treated, leads to the deformity at the proximal interphalangeal joint in the flexion, leading to the flexion deformity. And as I said earlier, I was mentioning that this lateral band or a lateral slips, which is joined by the tendons of the lumbricals and interosseous, in the patient with the in the patients with the boutonniere deformity, instead of sitting on the dorsal aspect of the axis, it moves down. So when it moves down, what happens? It creates a it stops to act as an extensor at the PAP joint, and that leads to the further flexion of the PAP joint. But it acts, because it is attached to the base of the distal phalanx, it acts as a extensor, and it extends to the it causes the extension of the distal interphalangeal joint. So this shift of the lateral bands is of paramount importance in understanding the boutonniere deformity. This downward slip leads to the contracture of the retinacular ligaments. These ligaments are shortened, and again it further pulls down the lateral bands, and it increases the flexion deformity. So that's the pathology in the patient with the boutonniere deformity. Now let's talk about the pseudo-boutonniere deformity. Now pseudo-boutonniere deformity is the one where the central tendon is intact, but the contracture occurs because of the injury to the soft tissue stabilizer. So that's the basic difference between the boutonniere and the pseudo-boutonniere deformity. The pseudo-boutonniere deformity has got a fixed flexion at the proximal interphalangeal joint and the hyperextension at the distal interphalangeal joint. But pseudo-boutonniere deformity may may not have the hyperextension at the distal interphalangeal joint. So that's as far as the basic anatomy of the IP joint is concerned. Now let's talk about some advanced move from the basic to the advanced anatomy. So as I said, in the pseudo-boutonniere deformity, your central tendon is intact, and the supporting soft tissue structures are responsible for the deformity. And what are the structures involved? You may have involvement of the volar plate, and it may lead to the contracture. You may have a long-standing PIP contracture, which may lead to the adhesions and various soft tissue abnormalities. You may have a reduced central slip excursion because of the adhesions, and you may have a triangular ligament laxicity. So as I told you earlier, triangular ligament holds the lateral slips on the dorsal aspect of the middle phalanx and the distal phalanx. But if this ligament is injured or it is lax, it causes the downward or a palmar displacement of the lateral ligament and causes the secondary contraction of the retinacular ligament, which causes the fixed flexion deformity of the interphalangeal joint. Now let's talk about the anatomy of the interphalangeal joint. Now interphalangeal joint we are talking about the proximal interphalangeal joint is the hinge type of joint where only the flexion and extension occurs. And this flexion and extension occurs because of the typical bony anatomy where the condylar head of the proximal phalanx articulates with the depression in the base of the middle phalanx. Now the most of the stability comes to the interphalangeal joint by this bony anatomy. And if you look at this interphalangeal joint, it has got a box-like appearance. Box-like means it has got a box-like soft tissue structure, and this box is made up of volar plate on the palmar aspect, which abuts the proximal interphalangeal joint. Then you have the soft tissue structure in the form of the proper ulnar and the radial collateral ligament, which extends from the head of the proximal phalanx to the base of the middle phalanx. Then you have the accessory ligament, which is the ulnar and the radial ligament. And this accessory collateral ligament arises from the volar plate and attaches itself to the head of the proximal phalanx. Now, if you look at the anatomy of the volar plate, the volar plate it is a fibrocartilaginous structure which prevents the hyperextension of the proximal interphalangeal joint, and it allows the complete flexion of the proximal interphalangeal joint. So it has got a distal attachment, which is a shorter attachment and a tighter attachment. And in contrast, it has got a proximal attachment by the ligament. These are called the check rein ligaments. And these ligaments, between the bone and the ligament, there is a space. So if there is any fluid collection in the interphalangeal joint, it tends to get gravitated more proximally than the distally, displacing the volar plate. So that's the anatomy of the volar plate and the collateral ligament. And of course, the superior aspect of the box-like configuration of the interphalangeal joint is formed by the lateral bands and the central slip of the extensor tendon. So that's the anatomy of the interphalangeal joint, proximal interphalangeal joint. Now, this is on the left, we have the gross picture of the palmar plate. So this palmar plate is a fibrocartilaginous structure like the menisci. It is indented, or there is a cleave in between in the volar aspect to allow the flexor tendons to pass through. As I said, proximally, it has got a very loose attachment. This is called the check rein ligament, and distally, it has got a very tight attachment to the middle phalanx. And this is again, that's the gross anatomical picture showing the volar plate. Now, if you obtain a longitudinal image on the volar aspect of the proximal interphalangeal joint, what you are going to see, long and the short axis image, what you are going to see, the lateral slips of the flexor digitorum superficialis. This has already divided at the level of the proximal phalanx. On the top, you have the flexor digitorum profundus, and on the dorsal aspect of the flexor tendon, you have the volar plate. As I said, it is a fibrocartilaginous structure. That's why it appears hyperechoic on the ultrasound. And then this is the normal appearance of the volar plate on the short and the long axis. So now let's come back to our case 1. Let's talk about the case 1. As I said, this is a 37-year-old male patient who had injury while fielding, resulting into hyperextension at the proximal interphalangeal joint while catching the ball. This hyperextension injury resulted into the subluxation, but it was immediately reduced, and the athlete did not take a proper care. So over a period of time, after the 3 months, he developed what is called the boutonniere deformity. Now, what are the soft tissue injuries that we are likely to see in the boutonniere deformity? Before that, let's look at the radiographs. That's the lateral radiograph showing the hyperextension at the metacarpophalangeal joint. Then we have a flexor deformity at the interphalangeal joint, and we have a hyperextension at the distal interphalangeal joint. On the AP view, we have some amount of the deviation of the proximal interphalangeal joint on the radial aspect, and for foreshortening of the proximal interphalangeal joints. So that's the radiograph. And as I said, never sacrifice radiograph in favor of the high-tech imaging, because sometimes the most of the diagnosis is made on the plain X-ray, and the clinicians do not require any advanced imaging technique for the treatment purpose. So this is the long axis view, which was obtained at the level of the proximal interphalangeal joint using the water bath. We have used the hockey stick probe, 624 megahertz, and in addition, we have used the water bath. And if you look at this image, that's the proximal interphalangeal joint. That's the base of the middle phalanx. That's the head of the proximal phalanx. And if you look at this, we are not seeing the hyperechoic structure of the central slip of the extensor tendon. Instead, the hyperechoic structure is seen lying at the level of the head of the proximal phalanx. And this suggests that there is a complete eversion of the central slip from the base of the middle phalanx. So that's a tear of the central slip, which is the hallmark of the boutonniere deformity, which is likely to develop if there is an inadequate treatment or a suboptimal treatment at the initial acute phase of the injury. So if you look at this longitudinal image, which is obtained at the level of the diaphysis and the head of the proximal phalanx, you can see the extensor tendon, which is situated and retracted at the level of the head of the proximal phalanx. Now, if you keep your transducer along the radial aspect of the interphalangeal joint, you are expected to see the crisp image of the fibrillary pattern or an echogenic pattern of the radial collateral ligament. Instead of that, we have the ligament which is hypoechoic, thickened, and there is an echoic gap at the distal attachment of the radial collateral ligament. So this is suggestive of there is a complete tear of the radial collateral ligament from its distal attachment. In addition, if you look at this patient, there is, in addition, now when you obtain the image in a little oblique plane, you also get the injury to the accessory collateral ligament. Now, this is the transverse image, ultrasound image obtained along the middle phalanx. And if you look at this, there is not only the tear of the radial collateral ligament, but also one can see there is a bony fragment which is avulsed from the base of the middle phalanx, and this was not obvious on the plane radiograph. So sometimes the undisplaced bony avulsions can be appreciated better on the ultrasound in contrast to the plane X-rays. When the image was obtained on the palmar aspect or the volar aspect of the proximal interphalangeal joint, what we could see, there is an intact volar plate. There is small amount of the fluid which is seen, which is gravitated proximally at the level of the proximal phalanx. As I told you earlier, the volar plate has got a very tight attachment over the distal or the base of the middle phalanx, while the proximal attachment is very lax. So if there is any fluid collection, it likely to get collected proximally. And you know, one most important point, when there is a doubt whether you have the tenosynovitis acting flexor digitorum tendons or the joint effusion, you look at where the effusion, if the effusion is situated volar or a dorsal to the volar plate, it is in the joint. And if it is situated on the volar to the volar plate, it is a tenosynovitis in the presence of the intact volar plate. So that's a very important point which need to be driven home. The ulnar aspect of the interphalangeal joint in this patient showed the typical echogenic pattern of the ulnar collateral ligament, suggestive of a intact ulnar collateral ligament. So if you look at our report, we said there is a full thickness tear of the central slip, which is a hallmark of the boutonniere deformity. There was a full thickness tear of the radial collateral ligament, and with the avulsion fracture from the base of the middle phalanx. There was intact volar plate and there was intact ulnar collateral ligament. Now, it is very important to provide the graphic illustration of the ultrasound findings. This is very well appreciated, particularly by the hand surgeons, and particularly when you are looking at the wrist and the finger pathology. So if you look at this graphics, on the volar aspect, we have shown that there is an intact volar plate. There is an injury to the radial collateral ligament. There is a retraction of the central slip proximally. Sorry. Okay, so there is a retraction of the central slip. So this graphics conveys all the points which are supposed to be mentioned in our report. So this is the corresponding MR images. On the left, you have the PD coronal non-fat set image showing the hyperintense signal in the radial collateral ligament, while the ulnar collateral ligament shows the normal hypointense signal. And on the sagittal PD fat set images, you can see that there is a retraction of the tendon, central slip of the tendon at the level of the proximal head of the proximal phalanx. So that's as far as the case 1 is concerned. So let's recapitulate what sequence of events that occurs when there is an injury, hyperextension injury to the proximal interphalangeal joint, which is not treated on time or it is treated suboptimally. So primarily you have the central slip injury. This central slip injury leads to a PIP joint flexion, because what happens, the central slip, which is the primary extensor of the PIP joint, is lost, and the lateral band that causes the PIP flexion because of the hyperactivity of the flexor tendon. Now all the transmission of the force now occurs to the lateral bands, and this lateral bands cause the DIP joint hyperextension. Now this hyperextension causes the contracture of the retinacular ligaments and tightening, which push down the lateral bands. And when these lateral bands are pushed down, you have the further flexion deformity of the interphalangeal joint. And over a period of time, it leads to the boutonniere deformity. So this is the sequence of events that occur in the hyperextension injury of the proximal interphalangeal joint. Now let's come to the case number 2. This is a female, 32-year-old, who had a twisting injury 6 weeks back. And again, she also developed a deformity, which is a classical boutonniere deformity. And this is the classical radiograph. I won't go over it again. That's the deformity which is commonly seen. Now, if you look at the longitudinal image, which is obtained at the level of the proximal interphalangeal joint, you have the intact central slip. So that's though there's a boutonniere deformity, the primary pathognomic of the boutonniere is absent. If you look at the normal appearance of the flexor tendons in the longitudinal and the transverse view, you have the normal flexor digitorum and relation of the flexor digitorum and the profundus. So that's the normal appearance. And in this patient, there was an injury to the extensor accessory ulnar collateral ligament. Now, this ulnar collateral ligament you can evaluate by keeping your transducer along the lateral aspect of the finger by connecting the volar plate and the middle phalanx. And this reveals that there is injury to the accessory ulnar collateral ligament in the form of the thickening of the ligament, and there is a fluid collection suggestive of a tear. And if you look on the volar aspect, besides the tear of the accessory ulnar collateral ligament, you have injury to the volar plate, and this is the tear of the volar plate. So this is the dynamic imaging showing all the components of the injury. That's the injury to the accessory ulnar collateral ligament and ulnar, which is and the volar plate. So the radial collateral ligament on the interphalangeal joint was a normal. So the report of this was like a pseudo boutonniere deformity, which had resulted because of the full thickness tear of the accessory ulnar collateral ligament. There's a partial thickness tear of the volar plate. There's a normal radial collateral ligament and the intact central slip. So this is the hallmark of the pseudo boutonniere deformity, where we have a intact central slip. So again, it's always good to provide the graphic so that the lesions can be very well appreciated by the hand surgeons. So I would like to conclude my talk with the carry home message that the PIP joint injuries are very common. Most of the times they are neglected, which results into complications like flexion deformity. So treatment of the PIP joint injury are challenging due to the propensity of the joint to develop stiffness and the lead presentation, because it is not uncommon for these injuries to be dismissed at the initial presentation as a normal injuries and treated with the body taping. Treatment may be delayed if a patient does not seek immediate medical attention, or stiff and painful finger resulting in a patient who are suboptimally treated. Now, the injuries may involve the ligamentous structures like a volar plate and or the collateral ligaments, as well as the central slip. You may have an intra-articular fracture, subluxation, or a dislocation, or a combination of above factors. But because of the lack of time, I have not covered the other injuries of the proximal interphalangeal joint. Now, there is a controversy exists over the ideal surgical treatment of the severe proximal interphalangeal dependent contraction, and it is being found that the long-term outcome of the operative correction of the chronic flexion contraction of the proximal interphalangeal joints have been universally disappointed, whether you treat them with the surgical, or you treat them with the conservative with the various plates. So to conclude, VIP joint injuries, if not treated, leads to the stiffness, which could be on the extensor aspect or the flexor aspect. Identification of the central slip injuries of paramount importance to differentiate between the boutonniere versus pseudo-boutonniere deformity. And the most important, the knowledge of the relevant anatomy and the scanning technique is of paramount importance to identify which structures are involved in the injuries, which may help clinician in the management of the disease. So thank you for your kind attention.
Sir, this is mind-blowing. If there were Oscars in radiology, you would walk away with best picture, best cinematography, best director.
So thank you, Mohit,
Ankit,
for those
your
inspirational words.
diagrams are amazing.
Yeah.
Ankit,
Thank you, sir.
Ankit, na
Thank
diagrams
you.
are amazing.
Yes. I have just delivered the talk. It's
No,
all
sir.
credit goes to Ankit.
Your experience and is amazing. What I'm trying to say is, because what you were saying matched with the diagrams,
Yes.
understanding became easier.
And let me tell you, I have covered only the 50% of the anatomy of the extensor hood. It
उसमें
is
मैं
so
depression में गया,
complicated.
sir.
It is, three areas which I find difficult is extensor hood, brachial plexus, injuries. They are very, very difficult to understand the anatomy of these two structures. You
But
read
sir, you would
umpteen,
agree
yeah.
that the 24/6 probe is changing extensor hood.
Absolutely.
Yeah.
And it is, and let me tell you, in a week, we see at least 3 to 4 patients who have a contracture deformity. And whatever you do, that leads to the deformity and significantly affects the, day-to-day work of the patients. Yeah.
Right.
Yeah.
No, but phenomenal presentation, sir.
Thank you.
Wonderful.
Thank you.
So, these injuries, volar plate avulsion and all, they look, I think all of us see it in day-to-day practice, especially those who are doing X-ray reporting, and we just label it, and it might look very trivial. So, in fact, even the general physicians and every other, कुछ नहीं है, नहीं कुछ नहीं, chip fracture, chip fracture. And then these are the ones which actually lead to stiffness. This PIP joint is like the elbow joint, all right? It has a big propensity to develop stiffness if you don't treat it well. So initially, we used to tell the patient, "नहीं तुम खाली body taping कर दो, it is." But it's not a great advice to give. If a patient has an injury, ask him to go and at least see some orthopedic surgeon or something, because these PIP joint injuries can lead to a lot of stiffness. In fact, if you talk to the patients, they say, "अरे नहीं डॉक्टर वो मेरा एक साइड का उंगली देखो ऐसा ही हो गया, ऐसा ही हो गया." So they will show you that one side is already stiff, but that they're easy to accept. But now they know that because it has become stiff, the next time they come back to you to get some kind of a medical attention. So
Absolutely.
yeah.
मोहित, इफ आई मे ऐड, तूने वो सिनेमेटोग्राफी के अंदर बोला, उसके अंदर 50% आधा ट्रॉफी अंकित का भी होना चाहिए.
आधा नहीं, 90%. I have just delivered. What happened? I prompted him that we must talk on this topic
Absolutely,
because this
sir.
is so common. I tell you, in a day-to-day practice, it's very, very common, and most of the patients are neglected by the general orthopedic surgeons. Let me tell you. my
Sorry,
one
Nidhi, I
of
had a phone call. You were saying
yeah,
something.
yeah. So
Huh?
You were saying something. I just had a phone call. क्या हो गया?
हाँ नहीं, आई वाज सेइंग कि तूने सिनेमेटोग्राफी के बारे में बोला तो उसका 50% आधा ट्रॉफी काट के अंकित का भी होना चाहिए।
नहीं, वो सिनेमेटोग्राफी पूरा अंकित का है, मैंने बोला ना।
ठीक है ना, ठीक
Because I know
है।
वो ये सब लाइन
फैंटास्टिक
डायग्राम ये सब
इमेजेस।
इसका पूरा क्रेडिट अंकित को जाता है, because we know only Ankit can do this amongst all the people that do MSK ultrasound. खाली
नहीं
अंकित ऐसा कर सकता है।
नहीं रे, उपासना बावी करती है
right.
बहुत
हाँ,
ज्यादा।
करती है, उपासना
हाँ,
करती है,
बहुत ही ज्यादा टेंशन देती
but
है मुझे
अंकित
अपनी
अंकित
इमेजेस से।
गुरु है। उपासना is catching up, no doubt, but अंकित गुरु है, पहला गुरु अंकित। उपासना is definitely catching up, पर उपासना के images भी उतने ही अच्छे रहते हैं, so no doubt about it.
सर,
So,
आई
but
एम
this
गोइंग
was
टू आस्क यू अ
phenomenal. The
क्वेश्चन।
understanding was better because your line diagrams were very matching to what sir was saying, and that made understanding better. I don't think I ever could have done a talk like this. Sir, phenomenal talk, sir.
वेरी
I
नाइस।
think
No,
this
no,
should
no.
go into this should go into international events, sir.
Thank you.
वो
Thank you.
international level का talk है.
Yeah,
Sir, two questions.
yeah.
So this is a real advanced talk, and you have included almost about 6 to 7 structures, volar as well as dorsal. So for
Yeah.
the beginners, if from an orthopedic point of view, so when an injury does come, whether so what are the common injuries and what are two basic structures that you would want a beginner to pay attention to and to tell the orthopedician so that he gets a general idea as to whether this treatment or the surgery goes what way. तो अगर जैसे तो dorsum के ऊपर, what are two main structures that you would like us to really pay attention to and make sure that you see that structure and you give a detailed description of that to the orthopedician? Dorsal.
So, Nidhi, what we have spoken today is the injury to the soft tissue structure following trauma, the sports trauma or the trauma after the fall. But it's besides the trauma, there are other causes which are very important. The one is the rheumatoid arthritis and
Correct,
the
sir.
burns injury, where there are a lot of contracture occur because of the adhesions.
Right, sir.
So, if you are looking at it on the dorsal aspect, you have to tell the clinicians about the injury to the sagittal band or there are adhesions. See, what are the treatment now? Let's talk about the treatment of the interphalangeal joint flexion deformity. So there are 3 A's. You have adhesionolysis, where you remove the adhesions which have occurred between the between the soft tissue structures and adjacent extensor apparatus or the flexor apparatus. The second is the arthroplasty. So this is done in arthroplasty when there are joint space narrowing or the patient does not, that different consideration where the soft tissue structure does not help in the getting over the deformity. So that's a arthroplasty. The arthroplasty can be usually done either using the volar plate arthroplasty or they call what is a hemi-hemet arthroplasty, where they remove the hemet bone and treat it. And the third is the one where if there is a fixed deformity, there is no improvement, you do a arthrodesis, which loses. But arthrodesis you cannot do at the metacarpophalangeal joint because that is the one which is very active. You can do arthroplasty at the level of arthrodesis at the level of the proximal and distal interphalangeal joint. So the cause is very important. Rheumatoid arthritis, you have to tell them what is the injured structure, whether it's a sagittal band or it's a radial or a collateral ligament, and what boutonniere deformity is there in a central slip injury. And from the volar aspect, you have to look at all the structures which I have mentioned, and so there is no shortcut. The most important structure. So if there is a contracture from the volar aspect, they do first structure that they dissect or the cut is the fascia. There is a between it is called a fasciectomy. If the contracture is not resolved, then the next stage is they treat the volar plate and the Chakra ligament. So I mentioned the Chakra ligaments are the one
Mhm.
which extend from the volar plate proximally and attach
Absolutely,
to the,
proximal.
and this is a very favorite ligament of the hand surgeons. They want to know what is the status of the Chakra ligament. So in spite of release of these two structures, that is a fasciectomy and the release of the volar plate and the Chakra ligament, if it does not happen, then the patient has to either accept or they have to further go for a treatment in the form of the arthroplasty, and that's the next line of a treatment which is offered. So that's all depending upon the amount. So it's a stepwise pattern how you keep on doing the first, but the first treatment is always conservative by using the various splints. You apply the splint in the dorsal extension, in the extension. If it doesn't work, then the surgical treatment comes into picture in the form of the fasciectomy, ligament release, volar plate release, reconstruction of the sagittal band or the lateral collateral ligament. And if that does not work, you do the arthroplasty, volar arthroplasty, or the hemihemat
Is there
arthroplasty.
any role of PRP in it?
No, I have not read anywhere. I don't think so. There is any role of PIP in this,
Mm.
because if you
Orthopedicians
give
like to for
no,
the
if
volar plate.
no, Nidhi, you have to understand that if you give PRP in a patient who has acute injury, it is like you are postponing the definite treatment which is supposed to be offered to the patient. And most of these deformities occur because of the inadequate treatment or the delayed treatment. What happens when the patient gets injured during the initial stage? There is a dislocation, and this dislocation either is corrected by the patient himself or people who are surrounding them, and or the primary physician who does not realize the gravity of the situation. Once the dislocation is reduced, the patient feels that I can be,
Yes.
I can be all right with the body
Right.
taping. And always it's a natural, people don't want a surgical treatment, but these are the
Mhm.
patients who need to be evaluated clinically, because if you find a laxity of 20 degree of the proximal interphalangeal joint in the coronal plane, that is on the lateral plane, that suggests that there is at least injury to the collateral ligament and one soft tissue structure which may be volar plate or whatever. So the clinical examination is of paramount importance, not only by the orthopedics, which I would suggest by the experienced hand surgeons, not by the general orthopedic surgeons.
Right.
And this is very much, emphasized in various papers and the talks, what I have read. So don't give them PRP. If you give PRP, they are definitely going to land up after 3 months or 6 months by the contractures, and you are going to then, screw up the entire treatment that which active athlete likely to get.
Got
So
it.
don't talk about any injections or anything. There's no
Mhm.
role for anything
So,
except.
ma'am, I would like to, sorry, just comment.
Sure.
See, what happens is, anyways, that tear is going to heal by scarring with the joint contracture. So, once that contracture or that flexion has happened, what are you going to do with PRP? PRP, and this is such a delicate balance of all the extensor hood and all. If you read, it's such a delicate movement that
Agreed.
that regeneration is not going to help. You want that function. You don't want that regeneration. There's nothing to grow over there. So if you just talk to any hand surgeon, why do you want PRP? In fact, it just heals with appropriate splinting. So
Right.
yeah, I mean that's what I feel. That
Yeah,
if
so
PRP is
Ankit,
oversold.
what I was bringing this entire question around was that most of the proximal interphalangeal joint injuries that I have come across, there are very few people who come in the acute phase. I get them in a chronic phase more than 6 weeks. Either there is a thickening or there is a flexion deformity already, or there is a calcification sitting in the volar plate. So that was one thing. So मैं जो सर से पूछ रही थी ना, that if we can break it down, when there is a central slip gone, the lateral bands sag, and really even with the compact linear probes, linear array probes, it's very difficult to find the laxity. I don't get to see the lateral band. So I focus my entire vision on the stability of the tendon, the sagittal bands, the collateral bands, volar plate, and on a dynamic scan, sir, I don't know whether you observed that before the volar plate, when you do a dynamic scan, you can actually know whether this volar plate is pliable enough for surgery or it is gone. There is the smooth movement that you see. So I was just thinking that can we break it down into just 3 or 4 structures that the orthopedician can address? That is what my thought was, because to go into those finer details of the transverse bands, I don't know whether after an injury in a chronic phase, you can see those structures. I really
No,
don't get to see them in the chronic phase, sir.
no, I tell you, with this now hockey stick high frequency probe,
Right.
most of the things you see, they are much better seen than the MRI. That's what
I
that's the
agree.
that's the point which I want to drive. You have to, and in sometimes even in addition to 624 Pro, we are using the water bath, for to
Right,
look at the
right,
central.
sir.
So it's the images are fantastic. That the reason I decided, and I was just telling Ankit that I want to present this talk, but
Right,
it will
sir.
happen only if you prepare the graph. I am absolutely technologically challenged person, and I have to depend on Ankit. And really, I was very fascinated by this injuries. I read so much
Completely
about it,
agree, sir.
and
Completely agree.
yeah, yeah,
This
it
entire
will
mechanism is very fascinating.
fascinating.
Very
Yeah.
fascinating.
And there are a lot of references. Let me tell you,
Yes, sir,
once
there
people
are.
know that you can give this information, they will come to you.
Absolutely.
And we are doing it. I'm telling you, we are
Uh-huh.
doing. Right.
No, but sir,
Not-
you're blessed with good surgeons also.
Yes,
We've
yes,
got
we.
just one. When you talk of a hand surgeon in entire Delhi, एक वो जो डॉक्टर विकास गुप्ता है और विवेक गुप्ता in Medanta, that's the only, now
Wow,
he's come to Max.
Max,
But
yeah.
there are
No,
hardly any people.
no, Bombay, we have many
I
means,
know,
yeah,
I know.
lot of hand surgeons,
Very true, sir.
and so we are fortunate that we have good
Very
surgeons.
true, sir.
Yeah.
Very true.
Any questions? Anybody else?
So I think to answer Dr. Neeti's question, that maybe one thing what you should start with as a beginner when you have a patient like this, just start with identifying is there a central slip injury or not. So
Right.
maybe the other thing might be a little bit challenging because let's say you don't have a hockey stick probe, chalo, you don't have it. But what can you do with what you have? At least start looking at the central slip.
Correct.
Try and look at the collateral ligaments because I think collateral ligaments should be a little bit easier.
Easy to see, yes.
Yes, because it's just on either side. Because
Correct.
once the finger is flexed, you might not be able to see the volar plate, so that you can just leave it. So even if you tell that orthopedic surgeon that yes, the central slip is intact, he will figure out. He knows that
Right.
what is the mechanism. So a
Agree.
lot of them they will just write it on paper. तुम खाली मेरे को बोल दो कि central slip injury है कि नहीं. I will deal with everything else. So I hope I've answered that question.
Yeah, absolutely.
Yes.
I agree with you. I agree with you that a few details which are really important to the surgeon, like the central slip, like the volar plate, like the radial collateral ligaments, and I think we have sorted out most of the questions of the orthopedician. Very agree. I agree with you.
In fact, not all the patients will undergo any kind of imaging for other than an X-ray. Let me tell you, I'm talking about 70% of it. They just look at the radiographs and they see the boutonniere and they know, chalo, flexion hai, extension at the DIP, and they know they don't need ultrasound for that.
Right.
But if it comes to you, at least this is the least what you can include in your report that yes, central slip is intact or not. At least tum itna kaam karo.
Right. I agree. I agree there. But fantastic.
Yes.
So, thoroughly enjoyed it. Amazing.
So this talk
Mesmerizing.
should be in Chile, sir.
Yeah.
Mesmerizing.
This
Absolutely.
talk should be in Chile. You can
Yeah, yeah.
change your talk, sir. This is truly an international level talk.
Yes, yes, yes. Yeah, so Ankit is
So,
coming. Let Ankit speak on
yeah,
this topic.
please, no,
Yeah.
no, great.
Ankit,
I think we,
first
I think we should include this in our national talks and then maybe take it to Chile. I mean, you know, our
No,
people
no,
should
no,
know
Ankit,
about this.
Ankit, I
Yes,
can tell you this will be the best talk in Chile. I can vouch for that. And किसी को कुछ पता नहीं होगा, तू मान मेरी बात, इसको दे दे भाई Chile में.
Agree.
right.
Absolutely.
No, but I agree with you, Mohit. I agree with you
Yeah.
so much.
So I'm telling you, this is the best talk there. You can take it from me. You please present this.
We will do that. Let
All
me
right.
talk.
and
Yes.
it's not as I told you, this is the part of the we have so many cases which are different pathology, but because of the lack of time we can't include, but
No,
the
but
Yeah.
con-
but
yeah,
half
so
an hour के लिए ये दो बस है sir.
was
And you yeah.
yeah.
But it's,
Mm.
Ankit, seriously, it's a
Yes.
sincere request because see, we are representing our country. We are not just representing a society. We are representing as to what level of scan we do in India.
Yeah.
So
Yes.
जिसको भी कुछ भी थोड़ा भी if there is a misconcept about what scans we do in India, it will all clear it.
नहीं ऐसा तो
Right.
नहीं हैगा. अभी I was just looking at their promotion flyer. और promotion flyer के अंदर सर उसमें लिखा हैगा the countries participating. The first one is USA because it is Music. So most of the speakers are coming from US. The second is Spain because Spain. The third is India, sir. There are
Yes,
24 countries participating and the third
Yeah.
one is India.
Yes,
But
yes.
what I mean to say was that the quality of ultrasound that we do
Oh, I agree.
is and this talk is the best reflector
I
of
agree.
what. So, Ankit, do think about it seriously.
Yes, sir. I will. Yes, sir. Thank
Yes,
you.
sir.
Great.
Right.
So,
Okay. So,
thank you everybody for joining. Yeah, Dr. Mohit, please go ahead.
no. Please, closing statement from you.
No, I think, sir, you should give the closing statement. Since I did the opening, you can close it. Absolutely
No, I
okay.
mean, it is wrong to use an eye opener in a closing statement, but this is an eye opener kind of talk, and I am truly blessed that we have people like you who's going to lead the society in the future. You're going to inspire generations to come and keep doing the good work. This is absolutely, I mean, I just can't stop praising this talk.
It's absolutely.
Thank you so much.
And
And
Neeti, special congratulations to you too, because apophyseal injuries, I mean, I'm telling you, I learned a lot. Though I joined a bit late, but I learned a lot as it went by, because I don't get these cases at all. So it was very good. So I'm quite happy with the way things are going now. And I think both of you should think of presenting this. Even Neeti, you should think of presenting this in national as well as international conferences. You will certainly shine out.
Thank you,
Good
sir.
job, both of you.
Thank you. Thanks a lot, Mohit.
yes.